my name is Nada Sudhakan. I'm a pediatric surgeon, basically a surgeon for children. My special interest is in keyhole surgery in children. What about circumcision in the boy child? It's a controversial topic. There are different reasons for and not doing circumcision. Of course, we will not talk about the religious or cultural circumcision. Even then, the incidence of circumcising boys are becoming younger and younger, and more children are being circumcised in Malaysia when they are newborn. My personal preference is not to circumcise boys until they are much older, when they are 10 and above years of age, before they get to puberty, for the religious or cultural ones. Other than that, in terms of non-cultural, non-religious circumcision, I would not advocate doing circumcision if not required. There are tendencies towards not circumcising boys, especially in Europe, where certain countries have banned circumcision for non-essential reasons. So basically, as a doctor, I would not fix something that's not broken. Some centers are providing circumcision at birth, and I think at birth the child's penis is much smaller and the risk of complication is slightly higher. Although it may appear that the child may not be having too much pain, I think children do go through a significant amount of pain at birth too. The only difference is that you can hold them down easier, and it can be done pretty quickly. The only issue is that because the penis is so small, the structures are not so clear. Therefore, the complications such as inadequate circumcision, where you don't take out enough skin or take out too much skin, is much easier. The other issue with circumcising at birth is that you might take off a vital blood supply to the head of the penis, and therefore causing the opening where the urine comes out from the head of the penis to narrow down. And this can be a problem as they go on through life and they have difficulties passing urine. And this can affect the bladder and the function of the bladder as they go on. Just to talk about infant stools, when the child is first born, they pass something called meconium, which is black in color and is tarry in nature. And that comes out within the first few days. And then once the child started feeding and they have milk, it becomes milk stools, which is yellowish and greenish in color. What is important is that the child is passing yellowish green color poo, and that should go on as long as the child is on milk feed. One condition which needs to be identified very early and be taken seriously is something called biliary atresia. This is a condition which is very rare, but if happens to any child, needs to be treated early, because the diagnosis and the prognosis, when done and identified early, makes a difference with the child's life. So biliary atresia is a condition where there is a progressive narrowing of the bile duct. The bile duct is a tube that leads from the liver down to the intestine. Why this happened, we don't know. It doesn't appear within the first few days of life, but as the child progresses, the bile duct from the liver to the intestine slowly narrows down. And this is probably due to some form of inflammation, but we don't know why. And as it progressively gets narrower and scarce, bile doesn't flow from the liver down to the intestine. Therefore, the stools that the child produces becomes paler and paler. So from a bright yellow color, it becomes slightly pasty yellow color. And that is a classic sign of biliary atresia. Not only that, the child will persist to have jaundice. So the neonatal jaundice that appear within the first few days of life or first few weeks of life should gradually get better. But if it remains after a few weeks and the child has got paler stools and the urine becomes more concentrated, more tea-colored, it is a sign that it is biliary atresia. So look out for these particular conditions. It's very rare, but the diagnosis and the survival of the child depends on how early it is diagnosed and treated. So this is a very rare condition, but if it's not treated and the bile flow is not corrected, the liver will start to fail. And when there's progressive liver failure and end-stage liver failure, the child will require a transplant. And transplant is not available in Malaysia at this point in time. Inguinal hernias in children are not that uncommon. Basically, a hernia is a protrusion of content from one area to the other. For example, in the inguinal hernia, the intestine comes to an opening in the muscle in the groin, and you see a bulge in the groin in your child. The incidence of hernias in children when they are first born is about 3%. So it's quite high. The way you identify hernias is a swelling in the groin, usually when the child is crying. When the child cries, you see the swelling, and then the swelling itself causes pain, and then the child cries even more, and the bulge gets more prominent. So it goes into a vicious cycle until the child calms down. The hernia, the lump, will then settle down. What are the complications of having a hernia? One is that if the intestine is coming through the opening, it can get strangulated by the muscle tissue. And strangulated means that the structure is being squeezed and the intestine with the blood supply is reduced. So basically, you cut off the blood supply to the intestine, and that part of the intestine is coming out will die. That's the worst case scenario. Most of the time, the hernia, the lump comes and goes, cause a little bit of pain, and sometimes cause the child to vomit because the intestine is blocked, and child vomits, and then when the intestine goes back into the tummy, it settles down. But once a hernia is identified, surgery is required because the hernia doesn't go away, and the complications, the younger you are, is higher. So when I identify a hernia in a newborn or a child who's a few weeks old, the operation is done soon as after we diagnosed it. I prefer to do a keyhole surgery because with the keyhole technique, we can put a camera into the tummy and look for both sides. So a child with a hernia on one side, for example the right side, may have a developing hernia on the left side, and the incidence of that happening is about 15%. So it's useful to examine both sides. Otherwise, if you just do the one side with the open operation, a hernia might turn up on the other side and will require another operation at a later date. So with the keyhole technique, with small incision, the belly button, and 2 other small scratches on either side, you can repair both sides if it's there, or otherwise you can just do the one side.